Good afternoon, good morning, good evening, colleagues who are joining this webinar. My name is Andy Seal. I work for the WHO Department of HIV, Viral Hepatitis and Sexually Transmitted Infections programs. My role today is just to welcome you and then hand over to the co-moderators. And really great to see that many of you have already started to introduce yourselves in the chat. That's wonderful. We will also post a couple of questions in the chat as we go through today's session for you to reflect to. So questions from us to you. But if you have questions from you to us, please use the Q&A box, and we will share recordings and slides with all participants at the end of today's session. We also have French and Spanish interpretation. Il y a des services d'interprétation en français, si vous voir le bouton en bas de l'écran. Y también hay interpretación en español disponible a través del botón en la parte inferior. So please do move to those languages as needed. So we have a great 90-minute session. Huge thanks from WHO to our co-organizers, to UNITAID, to the Medicines Patent Pool, and to IAS. And thank you, IAS, in particular, for helping us with the Zoom platform and the interpretation support. Very, very much appreciated. So let me now briefly introduce our two moderators for today. First of all, I'd like to say a warm welcome to Birgit Poniatowski. Birgit has been Executive Director for the International AIDS Society for more than 3 years now, and has more than 20 years of public health and international development experience. And with Birgit, we have Esteban Baron, who is the Head of Policy, Strategy and Market Access for the Medicines Patent Pool, where he leads on strategy development and partnerships to support access to health products. Esteban also has more than 20 years experience in public health. So Esteban is also standing in for Charles Gore today, the Executive Director, who is unavailable to join us today. Without further delay, I'd like to hand over to Birgit, and thank you again, Birgit.
Thank you, Andy. From me as well, a very warm welcome to everybody who is joining us online here today. Now, several of our speakers for today are with us in the room here at the WHO headquarters, and we're also very pleased to welcome a number of other speakers who are joining us online. Now, I'm not going to go through the full list of speakers right now. We will introduce everybody just before they take over the microphone. Now, today's session comes in two parts, and there are opportunities to engage online through the chat and Q&A functions, as explained by Andy earlier. Now, I'm delighted to be co-moderating with Esteban today, and will shortly hand over to him to walk you through what we hope to cover in today's webinar. Now, before I do that, though, let's reflect on why we are actually here today. Many of you will be aware that the World Health Assembly is starting next week. As usual, the WHO has an ambitious program of work. Among the items up for discussion will be WHO's next 4-year strategy and implementation plan, as well as the proposed pandemic agreement. The theme for this year's World Health Assembly is All for Health and Health for All. Now, Friday next week, the Assembly will review a number of progress reports, the first of which being a report on the first 2 years of implementing the global health sector strategies on HIV, viral hepatitis, and sexually transmitted infections. The strategy is for 2022 to 2030. Now, what we're doing today here is to launch the extended publication that accompanies the progress report. Now, as the title of the report suggests, important progress has been made, but also there are still significant gaps in the response to the 3 diseases to be noted. Now, at the IAS, we believe that science, policy, and activism come together, and only then progress will happen. Now we're sharing this conviction with our colleagues at the WHO and also at the Medicines Patent Pool. So I'm very happy that we have today a very diverse and engaging panel. I'd now like to hand over to Esteban to say more about today's webinar.
Thank you very much, Birgit. And I'd like also to extend a warm welcome to all those who are joining us today here in person, but mostly online. And to thank the organizers, of course, the World Health Organization, our colleagues from the International AIDS Society, UNITAID, and the team at the Medicines Patent Pool who have been involved in putting this webinar together. As Birgit noted, we will have two parts to this webinar today. The first part will involve interventions from colleagues at the World Health Organization and from a number of important speakers, including member states. We will hear from Jérôme Salomon, Assistant Director General here at WHO, from Meg Doherty, who directs the global program on HIV, hepatitis, and STIs. We will hear from the Ministry of Health of Rwanda, from the Ministry of Health and Social Service of Namibia, and we will hear from Patty Garcia, Dean of the School of Public Health at the Cayetano Heredia University in Peru. After we hear from the speakers, we will then move to a part two, and I will be moderating discussions with a number of other key partners involved in our collective work to address HIV, viral hepatitis, and sexually transmitted infections, including Philippe Duneton from UNITAID, Jessica Hicks from the World Hepatitis Alliance, Julia Martin, from US representative to the Global Fund, and Maureen Luba at AVAC. We have asked our speakers to help us draw global attention to the report's key messages, including the alarming rise in new STI acquisitions that you will hear about shortly when the report is presented. It's great to see that there are many of you already online and with such diverse backgrounds and of course located around the globe. Please use social media to amplify the messages you'll be hearing today. We think that there will be many inspiring thoughts and inspiring messages from our various speakers, but also several issues that are quite alarming and that are in many respects worrying and that we should also draw attention to. So today we do have to take time to celebrate the progress, but also to explore possible solutions to address the challenges ahead. We would like for you to all engage online. We have key leaders in the responses to HIV, viral hepatitis, and STI with us, both as speakers and also joining us as webinar participants. We also have a Q&A function in the platform, and colleagues from WHO, IAS, BP, and UNITAID are ready to engage in answering questions in real time. And we also hope that you might use the chat function to explore the following two questions. Firstly, how can we increase visibility, political will, and community activism to accelerate action across the disease areas that we're talking about today? Secondly, what urgent actions should be prioritized to help drive progress towards combined HIV, viral hepatitis, and STI goals and targets? I'd now like to hand back to Birgit to start the first part of today's webinar. Over to you, Birgit.
Thank you, Esteban. Our first speaker today is Professor Jérôme Salomon, Assistant Director General for Universal Health Coverage, Communicable and Non-Communicable Diseases at the WHO. Jérôme has been with the WHO for a year now, and as the title says, oversees a broad portfolio of technical programs covering HIV, viral hepatitis, sexually transmitted infections, TB, malaria, neglected tropical diseases, mental health, and a lot more. Jérôme was formerly the Director General for Health at the Ministry of Health and Prevention of France, including during the time of the COVID-19 pandemic. Jérôme, we would like to invite you to help further frame today's sessions. Why is a discussion like this important for the WHO?
Thank you very much, Birgit. Dear colleagues and friends, good morning, good afternoon, and good evening. HIV, viral hepatitis, and sexually transmitted infections continue to pose a major global health challenge. The report we are launching today celebrates significant progress, while also describing gaps in our responses and some problematic trends, including new estimates showing a rising incidence of syphilis, which raise major concerns. Despite our best efforts, we will not meet the global targets for 2025 and 2030 agreed at the 75th World Health Assembly unless we have a significant acceleration of focus and effort. We have the tools required to end these epidemics as public health threats by 2030. We now need to ensure that in the context of increasingly complex global challenges, countries do all they can to achieve the ambitious targets to which they aspire. In addition to describing progress made by countries, the report also describes actions taken by WHO in support of countries. Dedicated teams at headquarters, regional offices, and in countries have demonstrated clear leadership in working with partners to develop and disseminate important guidance, deliver timely technical assistance, provide support in data collection and analysis, and to encourage and nurture innovation. This work requires ongoing and strengthened collaboration moving forward with countries, multilateral organizations, the private sector, academia, and perhaps most importantly, with communities and civil society. I am excited to see speakers joining us today from a diverse range of perspectives to celebrate achievements and to recognize where we now need to focus. We succeed when we work together. Thank you.
Thank you, Jerome. I would now like to turn the microphone over to Meg Doherty, who is the director of the Department of Global HIV, Hepatitis, and Sexually Transmitted Infections Programs. Meg has been working in this field for more than 30 years, including leading the normative and programmatic work of the WHO on expanding HIV treatment to all and reducing inequalities in access. Meg, we would appreciate you kind of guiding us, walking us through the highlights of the report and the key messages that it sends. Over to you.
Thank you very much, Birgit. And I'm very pleased to be able to present this report, which certainly is the work of many different people. And I'm just, whoops, let's see. I'm here able to present the key messages of the report on behalf of everybody. It's been a team of 10, 20 people all around the table who've been working tirelessly to get this report together. And what's important is we, on the eve of the World Health Assembly, this is an opportunity for us to take stock the first 2 years into implementing this integrated global health sector strategies on HIV, viral hepatitis, and sexually transmitted infections. And as mentioned, we're going to be looking at gaps and progress. And it's a mixed picture, as you've heard. And this framework has been developed both at globally, but also then disseminated into the regions and into countries. And there are actions that are needed to be taken by member states, from WHO, from other partners across the world. And it's a framework that looks at defining both priority impact and coverage indicators and policy milestones. And I think at this point, we want to be able to ensure that we're looking forward and ensuring that if we do see any challenges, that we're taking action early. The new piece in data that I think we've had a press release come out today, and I would like to draw your attention to, is around the new data in syphilis. Pardon me. So from the report, and I encourage you all to look at the report, open it up and take a look at the data in there. There are chapters on HIV, hepatitis, STIs, as well as commonalities, and a chapter on accountability. Overall, deaths are not declining fast enough. The report shows that 2.5 million deaths have occurred each year across these three disease areas. And earlier this year in April, we also presented in a global hepatitis report that hepatitis-related causes are now causing 1.3 million deaths each year, which is on par with deaths from tuberculosis. New infections are not declining fast enough either. Now, we have data from 2022 for HIV, which is not new, and this will be updated as the new data come in July of 24. But we have new infections that are at 1.2 million for hepatitis B, 1.3 million for hepatitis C. But I'll draw your attention to syphilis, where across the board, we are seeing increasing approximately 1 million new infections in syphilis than were presented at baseline, with 8 million prevalent syphilis infection equal practically among men and women. So you'll see a mixed picture. Overall, 1 million new infections every day, driven primarily by STIs. New infections from hepatitis as well is a mixed picture. For hepatitis B, we see a slight decline in new infections, but an increase, if you'll see this trend here, of deaths from hepatitis B. For hepatitis C, we do see a decline in new infections, but a stabilization practically of hepatitis C related deaths. Again, we haven't done enough in terms of coverage and testing to be able to really change this trajectory. And for hepatitis, we have a particularly difficult situation because we have both a vaccine for hepatitis B and a cure for hepatitis C. The report also looks at what kinds of gains have been made in terms of service increase and access. And I think this is where you get the silver lining. We have had expanding service access. And in particular, across these three areas, it's in HIV where we've seen some of the greatest progress, where more than 75% of people living with HIV are receiving antiretroviral therapy now, and 93% of those have a viral suppression. And we have seen also 19 countries been validated for elimination of mother-to-child transmission of HIV and or syphilis, and at least 2 countries now in sub-Saharan Africa who have come forward for the path to elimination, and 1 for triple elimination of HIV, hepatitis B, and syphilis. These are all important progress that are notable from this report. But when we look at the impact indicators on incidence and deaths, we still, for HIV, we would like to draw your attention that we still have too many deaths, 630,000 in 2022. And when we look closely at the data, many of them are due to late engagement in care, advanced HIV disease, and other issues related to structural barriers and service access, as well as serving key populations in the most vulnerable persons. For hepatitis, I had alluded to this, but for hepatitis B, only 13% are actually getting diagnosed, 3% getting on treatment. That's far too low to be able to meet our targets. For hepatitis C, 36% diagnosed and 20% on a curative treatment. Again, we had hoped to see, because treatment is now approximately $60, $40, or in some places even lower for a full cure, that we would have seen this innovation really diffuse across the world. And lastly, an important vaccine, the hepatitis B birth dose vaccine that can reduce the mother-to-child transmission of hepatitis B, is at 45%, below the target of 70%. And if you look at the slides there on the left, you can see in sub-Saharan Africa, the coverage of hepatitis B birth dose is at 18%. Again, unless we change that trajectory very soon, we will not be able to stop the number of new infections for hepatitis B. Now, let me get to STIs, where we'll do a bit of a deeper dive. Many of the indicators for STIs are off track. When we look here at the image to the right, We have gonorrhea case notification per 100,000 populations in selected countries. Now, we can do this only in selected countries because of the data systems that are stronger there, and we'd like to be able to have data from around the world. But you can see in that trajectory over time that we're seeing an increase in gonorrhea. We also have seen that this must be also an indication that other STIs are likely on the increase, and we need to be able to measure those better as we move forward. On syphilis in particular, where we have a team that's done an incredible job to make new estimates, we've seen an increase in adult and congenital syphilis and we see this coming out of the COVID-19 pandemic, where we had set out an ambitious target of reducing the number of adult syphilis infections tenfold from 7.1 to 0.71 million by 2030. This year, 2 years into our strategies, we're seeing an increase of over 1 million or nearly 1 million, reaching 8 million prevalent cases of syphilis. This is primarily being driven by both increases in the Americas and Africa, but I think this is something we're going to have to watch very closely. This has led as well to 5.23 cases of congenital syphilis per 100,000 live births in 2022. Again, above the expectation that we would be 2 years in. Lastly, I'm just going to speak to accountability. We have a last chapter in the report that is looking at, are we doing the actions needed to be able to change these trajectories? One example of this accountability is WHO does do the work around norms and standards, and we follow the innovations and how they're being implemented. And we have seen 76 countries implementing a dual HIV syphilis rapid diagnostic test at national level. And again, this is a great example of where we're going to be able to perhaps scale this up and get that into other parts of the world to be able to address our increase in syphilis infections. And there are many others. This slide is way too busy for you to look at, but I would just mention that we have great examples from each of the WHO 6 regions where they have their own strategies and they've taken their own approaches to trying to address some of the targets that we have. When you look at the report, we outline in each chapter some of the urgent priorities that need to be taken to be able to get us back on track towards 2025 and 2030. We have shared approaches across person-centered response. One of them is really working at national level sustainability plans, working to consolidate some of our disease-specific guidance and implement a primary healthcare approach, address stigma and discrimination. For us, we're looking at a multi-disease elimination approaches, and lastly, to ensure we're focusing on primary prevention. We have many others for HIV, viral hepatitis. One thing I would just alert you to is that we want to be able to have a sustainability plan for HIV, but that should include looking at hepatitis and STIs and addressing, if we can, when there are new innovations, such as long-acting antivirals for prevention, as well as treatment, as well as, we hope, one day an HIV vaccine. And for hepatitis, the innovations don't have to be so new. We have the innovations. We have a vaccine. We have a cure. So now it's about how do we help countries have access to these quality access prices and to look to decentralize the work that we've been doing there. And lastly, for STIs, I think this is when we speak about it, it's the epidemic or the pandemic, one might say, that it goes ignored all the time. It is very much ignored in our public health responses. We're aiming to bring the visibility there, collaborate with communities, overcome stigma discrimination, work in the private sector, work with communities so that we're actually identifying STIs, testing for STIs, treating for STIs, and strengthening the national data collection systems. And lastly, just to say, working forward, we will have to report out every 2 years to the World Health Assembly on these actions. And we hope by 2026, we'll have better news. But at that point in time, if we have to look at our targets and readdress some of the actions and accountability we need to do jointly together with colleagues here around the table and in online virtually, we're looking to your guidance to help us to get us back on track so that we can actually say that we can address our SDG 2030 targets, but also all the strategies for WHO, Global Fund, as well as PEPFAR. So with that, I pass back to our co-moderators. Thank you very much.
Thank you, Meg. You have certainly given us a lot to reflect on. Yes, some progress has been made, but for me, the take-home message is a very sobering one overall. And the successes, in a way, are positive and also kind of send a negative signal, but why isn't more done along those lines? And because it can be done. And we will hear from our next two speakers on what that action could look like. So I'm now very delighted to turn to our next speaker, Dr. Sabin Nsanzimana, who has been the Minister of Health of Rwanda since 2022. Now, Rwanda has organized its programs in line with the global health sector strategies, grouping HIV, hepatitis, and STIs together. Rwanda is prioritizing testing and screening, prevention and treatment together with health system strengthening. Also, providing accountability by actually publishing an annual progress report in this area. Dr. Sabin has extensive experience in infectious diseases and non-communicable diseases program design, strategic planning, and implementation science. Dr. Sabin, the global view is a mixture of success and challenges. What have been the key learnings in Rwanda today? Over to you.
Thank you very much. So it's a pleasure to join you today, connecting from Kigali, Rwanda. The first speakers have made my job quite easier because these are partners we've worked with together for so many years in my previous role in HIV program, and currently overseeing the health sector in Rwanda as Minister of Health. And what has been happening here in Rwanda, like in any other country in Sub-Saharan Africa, has been trying to control infectious diseases, at the same time also fighting or controlling non-communicable diseases. So I would like to start by saying that we've made progress, and the report that we just saw from Dr. Meg has highlighted some of the areas we've improved and areas that we need to do more. And I would like also to mention that we're actually seeing more that can be achieved with the advances in technology, in scientific research, but also lessons we learned from previous challenges, including the COVID-19 pandemic. Although there are some setbacks we got from this pandemic, but also we learned that we can do things faster, better, and more efficient, and working together to tackle these diseases is possible. So I want to highlight the importance of the lessons in HIV response in the last decades. In Rwanda, we started by integrating the response to HIV together with malaria, TB, HIV, all programs into one umbrella. The Rwanda Biomedical Center has been a key implementer. Avoiding vertical programs in implementation has saved a lot of resources and focused ownership, but also decentralizing to the community. We've seen progress and achievements that actually in the last report that UNAIDS was published by UNAIDS highlighted Rwanda being able to achieve 95 people tested, treated, and viral suppression for HIV. But we've seen also the possibility to see challenges within even these 95 achievements. That is not enough to see it as at a bigger picture. There are also hidden small or important details to look at district level, at provincial level. For example, the eastern provinces, province of Rwanda being actually the area where we have more to do, both in testing, treatment, and also ensuring viral suppression is achieved. The issue of young people, actually, that's where we see new infections increasing. That's the only group, but in one province. That's why we targeted and shifted our strategies toward that particular area. So looking at these levels or granular levels of programs and data has helped a lot, and that this is probably the next step towards achieving or actually controlling HIV, TB, viral hepatitis, and the other infectious diseases while we deal with non-communicable diseases. The second point I want to highlight is the possibility to eliminate some of these diseases if we make it our priority, put it the emphasis, like hepatitis C. In the last few years, we made a commitment to eliminate hepatitis C in Rwanda. We started with a 4% prevalence of the disease. We had to screen 8 million people, and we had to achieve sustainable treatment for them. So over a period of 4 years, we've seen this screening happening. We partnered with different actors, and the results were actually very surprising in a good way, interesting, that the prevalence reduced from 4% to 0.3% on hepatitis C in the entire country, which is something that actually pushed us to even think of other elimination strategies. So we now on other diseases that we can eliminate, including, for example, cervical cancer and others. So as we look at this report, as we also reflect back at the national level, we see many opportunities to use the resources that are available in efficient ways, but also at the same way, integrated way, building health systems that will remain stronger for any disease burden that would put pressure on our healthcare systems. So moving forward, again, we want to reiterate the importance of multi-sectoral and also partners coordination. I see this meeting as a great way to show this partnership that is not only WHO, it's not only governments, it's not only societies or private sector, it's everyone, because at the end, it puts a pressure on all of us. I want to conclude by saying that the lessons we've learned from Rwanda, plus lessons learned from any other countries, put together can be enough to achieve ending AIDS, controlling hepatitis C, and even eliminating hepatitis B and hepatitis C. STIs can be controlled, and even beyond, because it looks like the next burden is actually double: infectious disease and non-communicable diseases. And dealing with both will require us to think more innovatively, more collaboratively, and only resources are not going to transform this situation. It's also how we use the resources, and also how we work together and how we engage our communities. So again, thank you so much for inviting Rwanda, inviting me to say a few words. And I want also to welcome you all next year to IS in Kigali in July. So thank you so much. Over back to you, moderator. Pleasure.
Thank you, Dr. Sabin. Thank you also for mentioning next year's IS conference on HIV science. I didn't dare. You've definitely kind of increased my optimism, and very importantly, what sticks in my mind from your presentation is your emphasis on working across diseases, on having coordinated plans, and then yes, having the synergies, being able to benefit from the synergies of doing just that. And we will hear more on that from our next speaker, who I am very happy to welcome here today. This is Mr. Ben Nangombe, who is the Executive Director at the Ministry of Health and Social Services in Namibia. Now, Namibia recently became the first high-burden country to reach a significant milestone on the path towards eliminating vertical mother-to-child transmission of both HIV and viral hepatitis B. We're very delighted, Ms. Nangombe, to have you with us here today, and would really like to hear from you what your learnings are. What are the key factors that helped you reach this point? Over to you.
Thank you very much, moderator, for giving me the floor, and also
we hear you, but we don't see you.
For
Oh, don't hear you well.
the raising this. Can you hear me now? My camera.
A bit
Are you
better,
able
but
to
we
hear
do
me
not
now?
see you. We hear you, but we don't see you.
My camera is very much on my computer.
You know what, your sound is also not so good. Maybe you would just want to turn off the camera, and we'll listen to your presentation, if that's okay. We go just on audio.
Okay, the camera is. Thank you. Are you able to hear me? Can you hear me better now?
It's a bit
My
better.
camera is off.
Yes, just go ahead.
Oh, it's unfortunate. Yeah, I was saying that Namibia is pleased to participate in meeting the lessons and
You're breaking off.
HIV viral.
We actually don't hear you well. Would you maybe try and reconnect?
Okay, I will try and reconnect.
Okay.
I'll try and reconnect.
Good. Thank you.
Thank you.
Should we do that first? Can you handle the communication? Okay. All right. Patty, if we do have you online right now, we'll swap the next presentations and move to you first, if that is okay. So moving from Africa to South America now, and in fact to Peru, I'm happy to introduce our next speaker, Patty Garcia, who's the Dean of the School of Public Health at the Cayetano Heredia University in Peru. Patty is also the former Minister of Health of Peru and a recognized leader in global health, including through a focus on STIs. When we heard from Meg earlier, something that really stood out was the disconnect between the global ambitions set for managing sexually transmitted infections and what is happening on the ground. And it is really truly sobering that we were close to 1 million new adult syphilis acquisitions in 2022 and 230,000 syphilis-related deaths. Now, what is driving this rise in new STI acquisitions, Patty? What can we do?
Do you have
Thank
the
you so
connection, Anand?
much.
Sorry.
Can you hear me well? Hello?
Yes, we
Excellent.
can hear you well.
Excellent. So, buenos dias, good morning from Lima, Peru. Actually, the rise in new sexually transmitted infections is more than worrisome. It is scary and it is frustrating. STIs have been always ignored and they have been the Cinderella of the infections. And the rise of these infections worldwide is driven by a complex interplay of factors. So, from the changes in modern dating scene fueled by dating apps and social media, the decreased attention to the use of condoms, and more conservative movements in the world and its effect in comprehensive sexual education, the emergence of antibiotic-resistant strains of bacteria, particularly gonorrhea, which really complicates treatment and control efforts, the lack of accessible healthcare services, but probably stigma is one of the most critical contributors to this rise, which is more evident in the key populations. And I will add in those key populations, migrants, indigenous populations, all of them usually suffering from discrimination and criminalization. So stigma causes many people to avoid looking for information and to avoid seeking STI-related services because of those terrible experiences of indifference, discrimination, or even hostility in the healthcare setting. So the question is, what can we do? And well, global STI prevention and control efforts required, in addition to effective public health infrastructure, a strengthening of the primary care level responses, adequate planning and financing, multi-disease elimination approaches, as we have heard before, and having packages, and innovations and technology for diagnosis and treatment for STIs that are the things that are very much highlighted also in the report. We also required a strong commitment and actions towards programmatic approaches to prevent and reduce STI-related stigma. And this requires the implementation of 4 key practices that I think had to be highlighted and implemented in all our countries. One is person-centered approaches that is very much seen in the report, and I applaud that. So these person-centered approaches relate to these systematic practices that emphasize communication, individuality, autonomy, dignity of the people receiving STI services, with respectful and non-coercive services that are led by staff trained in cultural competence, safety, and humility. That means investing in human resources training to make it more person-centered, to have these personal-centered approaches. The second key practice is sex positivity. That refers to clinical policies and approaches that acknowledge sexual diversity as a healthy norm, that acknowledge sexuality as a vital element that enhances individual and relational well-being. The third key practice is trauma-informed care or trauma-informed STI-related services, which should be able to respond to the complex consequences of the systemic and interpersonal violence and discrimination suffered by the people that are at greatest need of STI-related services. That will require working at the level of the programs and the clinical services to carefully review all the procedures, to train all the staff, to assure that there is an integration of these items into the interviews with people coming for services, and to have linkages to appropriate services. Finally, the fourth key practice is community engagement. Community engagement, understood as the meaningful involvement of people most affected by STIs, and include their voices, their perspectives, and working together to fight the mistrust that still exists and doesn't allow the populations to really be reached by our services. So to finalize this, I mean, stigma is critical. And although there have been great advances in the capacity to understand, to detect, and treat STIs, they are rising, as we've seen in the report. And it is very well highlighted in this discussion too. STIs remain key indicators of global health inequities that have worsened over the years. And so we need to act. Now is the time to systematically implement tools to confront, reduce, and eliminate STI-related stigma. This is quite critical. And this is a must if we really want to change the trajectory of STIs. So thank you so much for the report, for highlighting what is happening with STIs. To discussing this issue, we need to work against stigma and discrimination, and we have to do it together. Thank you so much for the opportunity of bringing this point into the discussion.
Thank you very much, Patty. Yes, and a very, very important perspective. There are biomedical reasons for increases in incidents that we see, but there is a lot to do on the political and on the social, cultural level as well, and particularly important here, including for fighting stigma, is to turn our perspective towards the person and away from the disease, and to design and provide services that reflect an individual in all their diversity, and quite practically, we keep talking about hard to reach populations. That's the wrong way to talk about it. Services are hard to reach by different populations, and we must make that much better. Now, Ben, I hope the connection is better now, so we can turn to you to talk about the experience in Namibia.
Yeah, thank you very much. Are you able to hear me better?
Oh, yes, it seems so.
Okay. No, thank you very much. I apologize for the poor connection. Technology lets you down at the most critical. Yeah, however, they are saying that Namibia is participating. It is an important plan. Each other has experiences on the intervention HIV, hepatitis, and sexually transmitted infections. Namibia has adopted the global health sector strategies on HIV infections into our national guidelines, our healthcare to implement guidelines. Similarly, we provide regular updates and orientations to our community healthcare workers who are advocacy, sensitization, and community education at household and community level. Over the years, we have witnessed a strategic shift in how communities to community involvement, monitoring, and leadership of the various responses. We as a country employ several interventions, models, and strategies that involve communities as activists, as peer educators, caregivers, access, for example, in the have representation in the National AIDS Executive Committee, NIC, and other key technical working groups about key strategies and
Just a message to the room, we can't hear you. Can you please unmute?
Is key. So apologies, Ben. I think we do need to leave it at that right now and move on to the second part of our meeting here today, which Esteban will guide us all through. So I'm very happy to hand over to you, Esteban.
Thank you very much, Birgit, and that's been a really interesting first part of the webinar. Lots of really interesting data and experiences being presented. The data, I mean, huge congratulations to WHO for all the work in collecting all of that data. But of course, the picture that's been painted by some of that data is quite disappointing in some areas in particular. But I also hear that we have the tools to end these epidemics, and this has been highlighted. So it'd be really interesting to also dive with our panelists now into trying to figure out where do we go from here and how do we take our response to the next level to get back on track with our targets. I'd like to point out that the chat function I've seen is very active, so that's great. Lots of interactions there. I'd also remind people, if you have specific questions, to put them in the Q&A function that is available on the platform, and colleagues here from WHO and other organizing partners will be seeking to respond. So now the global health sector strategies, as you probably all know well, have 5 strategic directions. The first 3 strategic directions cover services, partnerships and systems, and data. We've heard important insights into all 3 in part 1. And now for part 2, I'd like to turn our focus to other areas covered in the strategic directions, namely innovation and community engagement. And our next speaker is Philippe Duneton, Executive Director of UNITAID. Philippe, as you know, as you all probably know him very well, has been instrumental in creating UNITAID back in 2006, has been a leader and has been Executive Director since 2020. He has a long career focused on infectious diseases. And of course, UNITAID, as you're probably all very aware, has been a very important organization in terms of supporting introduction of innovations, spurring innovation, and really supporting all partners in this fight. So I'd like to turn to Philippe and ask him, how can innovation help accelerate progress for HIV, viral hepatitis, and sexually transmitted infections? Over to you, Philippe.
Thank you, Esteban. It's a pleasure to be with all of you guys. And I have to start to say that I'm very impressed to sit side to side with my friend and colleague, Jérôme Salomon, because every time he said, I'm in charge of communicable disease and non-communicable disease, I'm saying, and mental health, say, what the other guys in WHO are doing, you know? But I have some ideas, but still. So, and I think it's a joke and it's not a joke, because I want to highlight the fact that we need, and I think that's the sense of the message from a lot of people here and through Zoom, about the fact that we need to be specific in terms of what we want to achieve, but also comprehensive. And we cannot continue to have, of course, working in silos, even in silos with the response of HIV. It's totally contrary to our goals. And I think Meg was very eloquent on that. And I think it's really clear. The second point is, there are three mistakes that we are all doing all the time in public health. First, not to be serious about innovation. Innovation is a solution. Innovation is, of course, affordable access to the right product, but affordable access in the right hands. There is a component to the product, to the innovation, how to use it. And of course, we have seen that we put $120 million closely working with WHO to make the self-test for HIV, and then self-test for HCV, and then investing also in self-test for COVID. As an example, and I want to also say that the second point is we don't pay attention of the experience of the people who are the user of the system. We are the last sector of activities that doesn't give so much attention. Every time you go to an airline company or even a supermarket, you receive feedback. So now we have organized to have engaged with civil society, but frankly, every time, and we don't have the time, I have 20 examples when we do that, frankly, we have an idea of innovation that we don't have ourselves. And it's all the time, every time, and we should be serious also about that. Last thing that we are not doing is to think, which is a mistake, that poor people don't have the skills to change their behaviors, which is totally wrong. But how many times, think about it, somebody said, Africans, they don't have they will not use the innovation, they will not use IRVs and things like that. Guys, you think it's 20, 25 years ago. Last week I had that kind of remark, and it's not acceptable. So, well, I mean, one other thing I want to say explicitly is we have a united strategy, and we are enforcing it and developing it and integrated, not only for the fight of three diseases, including HIV, but also the co-infection, including cervical cancer, including hepatitis, but also women's health, and now PPPR, including oxygen. So I think it's really important, but it's not only the strategy of United. It's the strategy of the response from innovation and access to innovation point of view of the response. It's the translation of the priority and the strategy of WHO. That's what we do. And we do it with partners. So United is people-centered, product-centered, and how to use it, but it's also the partnership. When we don't find partnership to implement the good ideas of WHO and others, we create it, like the medicine patent pool, because it was an issue in terms of dealing with IP to make sure that to create a generic market. It's what we do. It's why we value a lot the work that we are doing with the medicine patent pool. And it's 10 years of introduction of dolutegravir. And you know what? All of you played a part into that. We were together to deliver faster, good quality, and we were together with Gélis and others in Cameroon, where it starts, where the clinical trial starts to demonstrate from NRS, by the way, idea that the equivalence with the treatment of reference. So I don't want to go into too much details, but it has a lot of impact, and we are driven by impact. We reach 200 million people every year. Well, it's not a lot of people, but believe me, it's the kind of people, if we don't support them, they will die. The pediatric, it's a patient that we have in common. No pediatric formulation, kids die. That's the counterfactual. People don't get it. So that's why we are so proud to work with you guys and working again on that. It's an acceleration. And we use the model of the Global Fund. We all do all the machinery. It's around 4 years of the advanced response. So without innovation, the pipe we have, and we are looking at that, we will lose 4 years. We don't have the machinery to do. So that's the impact of innovation. And of course, the savings was talking about dolutegravir. It's 1 billion a year for the next 7 years. 1 billion. Of course, the savings, it's for countries, it's for PEPFAR, it's not in our bank account, huh? Believe me. But it's important because it creates, and we know that money is quite important, the lack of money, lack of resource. So all the efficiencies are quite important and welcome. I talk about a lot of P's, people, product, partnership. There is another one, which our boss said regularly, is the planet. To take care of the people, we need also to take care of the planet. And unfortunately, we can see, it was not my priority, to be honest. For a long time, I said, frankly, we need to take care of the people who actually died. And planet, well, let's see. Well, now we see. And now we see that the most affected people, the 200 million I was talking about, will be and the most affected by this. So that's why we have a strategy also on that, and we share with our colleagues. But coming back to the dolutegravir, we decided to say, let's decarbonize the dolutegravir. And guess what? We can. Yes, we can. And we can do that by 60%. No magic, huh? Only work, which represent the carbon emission of the city of Geneva for a year, just one product. I can give a lot of examples, and we are with the colleagues of MPP, we have a lot of ideas to also engaging with industry and do this correctly. Last thing, last week, we have reviewed 2 important grants. And the first one is the triple elimination. We have been pushed by WHO with our consent to move into that because frankly, we believe it's the right thing to do. And is an example of consolidation for me that is obvious. I think I have to say that I've been really waiting, it breaks my heart not to have engaged more early, in fact, on hepatitis B. We are doing a lot of things, hepatitis C, but the situation with access to tenofovir is a scandal. And I think that we need to fix it. But the fact that, yes, we are about product, but in fact, it's the service to the people. So we believe that really this idea of triple elimination, and some of us were also in Brazil, where there is an announcement of the elimination. I will sign an agreement with PAO if WHO agree on that, but they will, to push also the agenda. I think it's really something that can be a game changer. I think Meg said it's absolutely key, and we are happy to take our part into that. So thank you. Big challenge for us, it's integration, and we are sure that innovation can do a lot to that. Over.
Thank you very much, Philippe, and thank you for reminding us of the importance of innovation to reach our targets and to be serious about innovation. And that we of course need to work in partnerships, And when those partnerships are not there, we need to create those partnerships. And the innovation is not just about commodities, not just about new technologies, but it is much broader than that. And it's also about how we engage with communities, is about all the work we do in health systems, on service delivery, etc., etc. I'll turn to our next speaker, Maureen Luba. Maureen is an African-based public health specialist and global health advocate from Malawi, serving as a senior advisor for global policy at AVAC. She also supports the IAS community-led monitoring program and some ongoing digital health interventions with Cooper Smith, among others. Now, Maureen, how can communities engage in existing data and perhaps generate additional data to make sure that we are creating an environment where partners and stakeholders can hold each other to account? Over to you, Maureen.
Thank you so much, Esteban. Just confirming that you can hear me and see me. All right. Yeah, so thanks a lot for the kind introduction. I think it's always an honor for me to share reflections and insights from the work that I'm doing with affected communities. You know, whenever I get invited to meetings like this, for me, I always take it as an opportunity to bring the voices of the people that are most impacted, you know, by the issues that we'll be discussing, that we're actually discussing today. I think for communities, it's always encouraging when we see, you know, communities being recognized as critical stakeholders, right? And partners in global health policy and program implementation. I think a lot of you mentioned about the importance of engaging communities. In fact, one of the strategic directions for the 2022 to 2030 global health sector strategies, which we are all reflecting on today, is to engage empowered communities and civil society, which I find to be such a powerful statement. And of course, there are so many ways in which communities can be empowered, right? Beyond funding and maybe giving them a seat at the table, which is, you know, those are the things that we normally talk about. I think as we are now seeing the increasing demand, right, for evidence-informed decision-making, one of the most powerful tools that could help empower communities is the access to data and information, like the one we're sharing today. You know, when communities have access to data and information, as well as the tools they need to interpret and make sense of that data, they become empowered, right? So what happens, you know, when you give community access to data, information, there are so many ways in which communities will use this information, right? I'll just highlight two because I know I don't have much time. You know, one, communities can use this information that we're sharing today or from our program data to identify areas where they can complement government efforts, right, in various disease responses. So this could be, for example, routine monitoring data that is highlighting, for example, populations that are left behind, or communities where we are seeing more new STI cases, or even facilities that are not performing well. You know, as communities, we understand that our role is not just to hold, you know, everyone else accountable, right? But we also understand that we have a role to play here, right? You know, in providing services, reaching those hard to reach populations that I think we're talking about, you know, in places where maybe government cannot reach there, you know, other implementers cannot, you know, reach those populations. But we are also there to support creating demand for the services that are being provided, especially in places where we are seeing low uptake of services. You know, for instance, from the report that we are all reflecting on today, you know, we know that the burden of STIs that's come out, you know, it's rising. We are seeing more cases being reported. Some studies have even suggested that, you know, the number of STI cases has increased as we are seeing increase in access, you know, to PrEP. Why? Maybe people are not using condoms, right? And I think as Dr. Megs, you know, mentioned earlier on, STI, you know, has been ignored. It's not just by the health system, but also even among communities. You know, it's something that maybe, you know, we take lightly, we think it's a disease of the past, but the burden is actually huge, right? And this is an area where, you know, community programs could actually benefit from a lot from the community interventions, right? They could help in raising awareness as why people need to continue, you know, using condoms, consistent use of condom, even, you know, when we have PrEP and other HIV prevention options available, right? right? Of course, this is just an example, right? There's more I know to address in terms of the STI burden. I know in most countries, including my own country, Malawi, we're still using syndromic management of STIs. And actually the number of people that we are seeing or reporting, to facilities with the STI cases, I think it's just the tip of the iceberg because most of the cases are asymptomatic. People are not seeing the same symptoms, right? So we need, of course, more point of care screening. As a world, as we are celebrating, in terms of prevention, doxaprep. I know for other countries like Malawi, where doxycycline is used as a treatment for gonorrhea, where antimicrobial resistance studies have actually shown high resistance, right, of doxycycline to gonorrhea. There's a lot we need to consider, right, as we're thinking about doxycycline as an option for STI prevention. Secondly, when communities have access to data and information, we can use it to hold stakeholders accountable, right? Policymakers, implementers. I know sometimes when we say holding, policymakers and others accountable, it almost sounds as a policy, right? But it's not policing. By the end of the day, I think as communities, as partners, as we keep talking about partnership, we all have the same goal, right? That is to make sure that the communities that we're serving have access to the services that we are providing them, right? Where they need them and when they need them, right? So coming back to your question, second question about can communities also, communities, we are not only consumers of data. We can also, help in generating data that can provide more insights in terms of where are the gaps in terms of service access, but also service delivery. I think you agree with me that a lot of the data that we collect at country level, routine program data, usually it focuses a lot on the numbers. How many people, had access to STI screening? How many people had access to cervical cancer screening? Or how many people missed their ART refills, right? And most of the times what we are missing is the why. Right? A lot of the program reports may not do a good job in explaining why are people not showing up for services, right? And this is where as communities we come in, because through our daily engagement and interactions with the communities, we are able to unpack the reasons why people are not showing up for services. And I think this information is very, very critical if you really want to address the existing access gaps. And oftentimes in most places where we are seeing no uptake to services, the reason is not that the services are not there. Oftentimes services are not there, but people are not just taking the services. I'll be wrapping up, but just wanted to mention that the past few 2 weeks, I've been with my colleagues here in Joburg. We are attending 2 workshops, one organized by IAS and another one by Global Fund on community-led monitoring. So both of these workshops, what they did was to bring together community representatives, civil society organizations, and researchers to discuss ways in which communities can continue to generate data through community-led monitoring to provide insights to those programs, right, in areas where we need to make some improvement. So what community-led monitoring does is communities affected by HIV, TB, and STIs and other diseases, they are able to monitor availability, accessibility, affordability, but also the quality of the services in different facilities, but also at community level, but also in hospitals. And so far, the community-led monitoring has demonstrated to be such a powerful accountability tool. And in places where it's being implemented, it has actually helped to bring to light existing barriers, structural barriers to health services, especially among key and vulnerable population. So in conclusion, CLM is being funded by Global Fund and PEPFAR and Gates Foundation, but more funding is needed. It's not enough, right? So as we continue to reflect on these strategies that we have discussed today, as we are preparing to review some of these strategies in 2016, even ahead of the meeting that's coming up, right? We need to reflect on the importance of strengthening community engagement. Let's find ways to create eco-partnership. We need more investments for programs like community-led monitoring. And lastly, there is no health for all without strong community engagement and eco-partnerships. Thank you so much.
Well, thank you very much, Maureen. That's a very powerful message. And of course, flagging the importance of data for evidence-based decision-making, but also for accountability and the critical role that affected communities can play in generating the data and using the data and putting a spotlight on the data and monitoring us all in terms of accountability and ensuring that we stay on track and that we do know needs to be done. What I would like to now perhaps move to Jessica. Jessica Hicks, are you with us online?
Yes.
Jessica is with the World Hepatitis Alliance. And of course, we've been talking about partnerships, about the important role of partnering across different stakeholders. The World Hepatitis Alliance has a large network of civil society and community organizations in more than 100 countries, but also partners extensively with governments, with other stakeholders. And the question to you is, from your experience, how can countries be better partners with affected communities? Over to you, Jessica.
Great, thank you, Esteban, and thank you to the organizing partners for inviting us to be a part of this important discussion. I'm really delighted to be here today on behalf of the World Hepatitis Alliance and echo Maureen in saying that it's great to see communities recognized as key partners throughout the discussions today. As you said, the Alliance is a network. We have over 337 members now in 102 countries. And we really work with them and other partners towards hepatitis elimination. And everything that we do is centered around the belief that elimination will only be reached by putting civil society and the affected community at the heart of the response. And I think, if countries are to really be better partners to the community, then we call on them to adopt this principle also. Really what we need globally is a paradigm shift where the affected community is not just seen as the end user of healthcare systems, but as the designers and implementers of that system. And it's been great today to celebrate successes like Rwanda and Namibia, but the data that Meg shared earlier was startling. For hepatitis, but also HIV and STIs. And it's clear that when we're talking about elimination, we are not going far enough, fast enough, and we need to do something different. And the progress report calls for country ownership and sustainability. And I'd really like to add to that if we are to address the barriers to elimination, countries must center meaningful partnership with civil society and the affected community in their responses. And, successful partnerships can drive forward innovations within countries and programs. And I'm going to share a couple of examples from the hepatitis community. And really, I do echo everything Maureen said around access to data. And I've focused on a couple of different areas, but I do think that the role that civil society and the affected community have to play is huge and it's broad, and they need to be across every step of the cascade. And while the examples are focused on hepatitis, the principles are applicable across all the disease areas that we're discussing today. So community groups are really expertly placed to raise awareness, increase education, and dispel the myths and misconceptions that continue to drive stigma and discrimination. Patty spoke really eloquently on the impact of stigma and discrimination on people living with STIs and the barrier that has in people coming forward for testing. And I think that those exact points are completely applicable to hepatitis as well. And so until we do something to address stigma and discrimination, we're not going to see the diagnosis rates increase. And World Hepatitis Day is a really great example of how countries have partnered with our members to amplify this messaging. And, I could probably speak all afternoon about the great work that our members have done on World Hepatitis Day in partnership with countries to raise awareness. But I would like to say that this is something that needs to happen more than just one day a year to have sustainable impact and address some of these barriers. Community groups also really understand the preferences of the communities that they serve and are able to help design services which cater to the needs of those groups. And they take, healthcare services to people rather than expecting people to come to healthcare systems. And I think this is especially important for marginalized groups or groups that may not access traditional healthcare systems as much. And a great example of this is the Hep B Pass program in the Northern Territory of Australia. And it's a partnership between government and multiple stakeholders, and especially the community. And as through this program, education materials have been translated into many Aboriginal languages. An Aboriginal work healthcare force has been trained, and services are being provided within communities. And that's really critical in Indigenous communities, which are often very spread out, especially in a country as large as Australia. And so through this, they've been able to establish this hepatitis B status of more than 33,000 people and linked each of those people to care. And so the impact of really having the community at the heart of that, shaping the response, can't be underestimated. They're also expertly placed to find people and link them to care. And, you know, again, the diagnosis rates are so low for hepatitis, especially hepatitis B. And so it's really going to be very important that countries partner with community groups to address that barrier. And the Hepatitis C Trust in England is a really great example of how partnership has driven diagnosis rates. And so through their peer program, they work within communities and prisons to find people, test them and link them to care. And it's been incredibly successful. In 2023, they tested over 25,000 people. And it's delivered and this is really important, as part of the national response, with the government recognizing and funding them as a key part of the national program. And I think this final point is really important because none of this can happen without funding. And so for countries to better partner with community groups, they need to ensure that they prioritize funding for those groups within their national plans so that they are able to fully resource the response. Finally, I just sort of want to point out that we're discussing today 3 diseases which can all either be prevented, cured, or managed with lifelong treatment, and yet 2.5 million people a year are dying. And this is just not acceptable, and we're failing the people who are living with these diseases. So we must take urgent action. And we truly believe that partnership between countries and empowered, engaged, and well-resourced community groups has the potential to really dramatically drive forward the response and get us back on track for elimination. Thank you.
Well, thank you so much, Jessica, for a very powerful message and for providing examples of the kinds of partnerships that we're talking about, in particular, the role communities can play in bringing the services to the people and in shaping the response in a way that is better suited to the needs of those that are needing those services. So thank you so much for sharing with us those examples and those experiences. So I do want to point out that we don't have a lot of time left. We'll have one more panelist. In the interim, if you do have questions, we may not be able to get to them live here in interacting with our panelists. But what I would suggest is please continue to put those questions on the Q&A function of the platform. And our colleagues here are really trying to respond in real time. And so really committing to having that space for you to be able to interact with the experts, but we may not have time for doing that orally here. So I do want to now turn over to Julia Martin. Julia has over 25 years of professional experience in health, focusing in global public health and on HIV. She is a senior health advisor and US representative to the Global Fund here in Geneva. Julia, the US government, through PEPFAR, is working with UNAIDS, the Global Fund, WHO, and others to support countries in planning towards sustainability. How can those joining this webinar support that work? And what are the key challenges and opportunities ahead? Over to you, Julia. Thank you.
Thank you very much, and thank you for the opportunity to speak today and for the report and for the original Global Health Sector Strategy document itself. And, you know, the challenges to faster progress in HIV, STIs, and hepatitis lie in a really complex set of issues, has already been discussed, and it is in the paper and directly affects the durability of the response. And that's unfortunate, but I'm an optimist. So sustainability applies to certainly what has already been accomplished, which is a lot, but it should also apply to what could be achieved. Plans and strategies must critically look at how to ensure that which has been achieved does not regress, and at the same time adjust delivery so it meets the challenges of the now and the near-term future. Nothing can or should stay the same, and trade-offs must be made, and this is actually the heart of the sustainability discussion. The global health sector strategies include health issues that are not the same. They're quite unique in their interventions and treatments, but in considering sustainability, the challenges are the same, and more can be achieved by working together. And I think that's been made several times over by other speakers. Like our colleague from Peru, I have 4 challenges I just want to focus on. The first is program. Evolve services that have been successful in the past to the EPI context of today, and focus on simplicity and delivery, protecting and prioritizing the most essential of services, and using community-driven solutions to ensure the effectiveness and durability. These will require letting go of some things and acknowledging that to cover more of the need across disease planning is essential. Those are easy to write and they're very difficult in practice. Country-specific tailored planning and implementation of all 3 diseases was highlighted in the report, and PEPFAR and I think the broader partnership around HIV believes that is true. Developing and using primary healthcare platforms and integrated delivery will do more with the same money we have, will expand testing and diagnosis and treatment for all 3 of these diseases. That is for certain. We just have to do it. The second challenge is a systems one. The explicit support for health systems that are absolutely necessary to sustain and grow health outcomes. Lab, human resources, surveillance, routine program data systems, and supply chains. Investing in these systems are not nice to have, but they're requirements for sustaining the results now and beyond. Underinvesting in siloed approaches hamper service delivery and create inefficiencies. The community health worker is a really obvious example of this. They're an important part of the delivery system in many countries in which we work with, and they're well positioned to offer cross-disease services. Again, easy to say, harder to do. The third challenge is policy. Pieces of paper have great influence. They influence what services are offered, how services are delivered, and who has access to them, and whether they pay for them or not. Policies either support or hinder all of these things. They drive health results in a positive direction, or they allow for increases in incidence. Addressing equity relies on good policies that map to science. Inequity expands unmet need. Full stop. This is clear in the growing incidence in specific populations, while not in others, in all 3 disease areas. Some populations have better access, safer access, unhindered access, while others do not. To sustain and grow positive health outcomes, overlooking inequity will bring us failure, not success. The faster we come to that realization as a collective, the better. The fourth is financing. Often sustainability discussions start here, but they shouldn't. Excuse me. Financing for health is a combination of getting the most out of money currently available and growing the top line. Program delivery must be tight and focused. It must be efficient. The hunt for efficiency shouldn't stop. If we had stopped at the early pricing of ARVs 20 years ago, we'd have a fraction of people on ART today. Innovation, like introducing new technologies Philippe spoke of, often requires upfront investment. It's more expensive, and we need to save in some areas to support new areas. It's not about growing the top line completely. We can do way more with what we have. Sustainability will ultimately rely on treasuries allocating and dispersing more to health. That's very true, to cover the systems and actual services, and should not be forgotten. Health needs to make that argument in all countries, and treasury needs to respond, and we need advocacy to get them to respond. PEPFAR has proudly invested heavily in the global HIV response and provided technical and financial inputs for many years. National responses have been amazing in the last 20 years. They've blown everyone away in what has been possible. No one, not the country leadership, not governments, not civil society, not communities or multilateral organizations, many who are in the room and online, and not the US Congress, want to see investments and progress be reversed. No one wants to see progress slowed. PEPFAR is fully committed to walking the sustainability path with countries and communities, just as much as it has in the last 20 years for growing the response. We're appreciative of the UNAIDS Countries Joint Program and all its partners and co-sponsors for facilitating discussions in countries. And the sector strategies is an excellent resource from which to build those discussions. So to end, all 4 challenges are connected. And as Brigitte said at the top of this briefing, science, policy, and advocacy work together, and together form a path forward. Sustainability is not linear. Revisiting and revising will be essential if the spotty results that Meg started with can need to be changed and transformed into a trajectory of positive results. I remain optimistic. I hope everyone else does too. Thank you.
Well, thank you very much, Julian. Certainly, thank you for the optimist note that you ended it with. I think it's extremely important. I mean, we have heard we've heard about where we are in the implementation of the strategies. We've heard areas where there's been good progress, but also various areas where we are off track. But we've also heard a lot of different approaches that do work. And that's, I think, the note for optimism is that there are a lot of lessons learned, that there are very interesting experiences being highlighted both here and in the report. We've heard from ministers, from governments, from global health agencies, from community experts. And I think there is certainly room for some optimism, although we also have to take into account some of the sobering data that has been presented today and really think about how we're going to approach the next few years to get back on track. I'll pass the floor now to Brigitte to close the webinar. Over to you.
Thank you very much, Esteban, and a big thank you to all our speakers and panelists today. I'm not going to repeat what everybody has said. I think all the important points have been made. Business as usual isn't working. The increase in stigma and discrimination isn't helping either. We know a lot of what to do, so let's do it. But I also find the point very important that we do need to shift our mindset to putting people first. And as Philippe was saying, this doesn't mean us thinking about what people might need. It's actually asking what people need and listening to the response and taking it into account. So again, thank you all for joining. But before closing, I do want to hand it quickly back to Meg as well, who in the end brought us all together.
That's very kind. And I'll be very brief just to say I'm very glad that we could end on an optimistic note, because if people know me, I'm nothing but optimistic. We look at the data that we're sharing today to give people notice that we need to do more. And we're going to be thinking this through, working with you all, and very appreciative for all of the excellent questions. I don't think we got to answer all of them, so we'll have to keep that open so we can answer the important questions. And I noted that we had more than 700 people at one point in time on this, this call. So clearly there's a need to share more of this information and to work towards our optimistic outcomes that we all want. So thank you very much for bringing us together.
Thank you. And with that, we close the webinar, but not the access to the Q&A function. Is that correct? So we will try to keep the Q&A function open. Thank you all very much.
Thank you.